So, what about the clinical signs? We notice that we have a late diagnosis because of non-specific symptoms. So when the signs appear, that means that we have already the wall which is affected or we have metastasis. So the presence of symptoms means that we have a poor prognosis factors. And only 10% of bronchial cancers are discovered in an asymptomatic stage, and this discovery it's due to a chest X-ray which was done incidentally. So any thoracic or extrathoracic symptom in a smoker should suggest the possibility of bronchial cancer. We have to complete the clinical examination and to do a chest X-ray. So, what about the clinical signs? We have signs related to the bronchial tumor, others to the local regional extension, to the metastatic extension, or what we call paraneoplastic syndromes. First, the sign related to the tumors. We could have cough, which is frequent, but is considered by smokers as normal because they have their chronic bronchitis, and it is really a reason for consultation. But we have to pay attention. If we have an aggravation, a modification, or a resistance to treatment to this cough, we have to do a chest X-ray. The second sign is hemoptysis. Even if it is minimal, it has to alarm the patient and prompt him to consult. So any hemoptysis in smokers or no smokers should lead to a search of bronchial cancers. And of course, if we do not find bronchial cancer, there are other etiologies like what we have seen, tuberculosis. The third sign is expectorations. We could have a surinfection of that cancer and having expectorations. And dyspnea, as cough, it is non-specific and often neglected because of the chronic bronchitis of these smokers. Secondly, the sign related to local regional extension. If we have an extension to the wall, we could have chest pain, which is progressively worsening and increasingly resistant to the usual treatments and causing insomnia. We could also have an extension to the apex, responsible of what we call cervicobrachial neuralgia, or an extension to the pleura, and it will be responsible of pleural type pain. We could also have a mediastinal extension. If the superior vena cava is involved, we could have superior vena cava syndrome, as we have see it last year in semiology. The trachea, we could have inspiratory dyspnea, and in the physical exam, a stridor. If we have a recurrent nerve involved, we could have dysphonia, bitonal voices, and hoarseness. If you have the phrenic nerve involved, we can have hiccups and dyspnea. The pneumogastric nerve, hypersialuria and bradycardia. Esophagus dysphagia, and the cervical sympathetic nerve will be responsible of miosis, enophthalmia, and ptosis, which is Claude-Bernard syndrome. Third, we could have signs related to metastatic extension. If we have metastasis and bone, we could have bone pain, and if we have metastasis on the brain, we could have some neurological manifestations like deficits and epilepsy. And fourth, we have to assess the general signs, to look for general signs, and those can be assessed by some scores that we call Karnofsky score or performance scores to assess the general condition of the patient. And we have to look if we have weight loss, asthenia, or anorexia. The final signs that we have to look for are what we call paraneoplastic syndromes. That signs can be present in 10% of cancers, and especially in small cell carcinomas. They can precede the tumor, regress with tumor treatment, and even recur in cases of relapses. The most important ones are rheumatological syndromes, and the first one that we always look for is digital clubbing, which is the most common, with a bilateral hypertrophy of the phalanges in drumstick-like drumstick, with bulging in wash glass of the nail. The second one is what we call Pierre-Marie hypertrophic pneumonic osteoarthropathy, which is a digital clubbing with hypertrophy of the extremities with the radiology of sheeting hyperostosis of the long bones. As we can see here, we have digital clubbing, and here we have Pierre-Marie syndrome with digital clubbing and hypertrophy of these parts. We could have also endocrine syndromes like malignant hypercalcemia, Schwarz-Bartter syndrome with inappropriate secretion of antidiuretic hormones responsible of hyponatremia with preserved natriuresis. We could have also hypercorticism with inappropriate secretion of ACTH, and the most important one of endocrine syndromes that we always look for in lung cancer is what we call gynecomastia. We have also others that are less frequent than those who we are talked about. We could have some neurological paraneoplastic syndrome like Lambert-Eaton syndrome with muscle fatigability, Denny-Brown sensory neuropathy, limbic encephalitis, cerebral degenerations, who are linked to autoimmune reactions with the presence of antibodies. We could have some dermatologic signs like dermatopolymyosite, myopathy, and encotosis nigrans, and also pulmonary embolism and recurrent phlebitis in the legs.